I know how to operate on arteries. Why shouldn't I know how to operate on veins? So very few raise their hands when Dr. Gavis asked how many of you are doing venous stents. So I assume the majority of you here are mainly operating on arteries. And I want to discuss a little bit the misconception that the fact that you know how to operate on arteries doesn't necessarily mean that you can operate on veins, because there is a misconception that operating on veins is something easy. You tend to downgrade it, and this is not the case. And if you want to operate on veins, you need to know how to operate on veins to make things right. You need to follow certain rules. So let's see now why it's not the same. If only the slides could change. The cursors do not work. Technical support? I cannot change the slides. Okay, it now changes. So this is how an arterial procedure looks like. You're very familiar. We're just watching live an aortic stent placement, or you can see how peripheral arterial disease and endovascular management looks like. We start from the basics. Look how the images look like. They're definitely not the same as this. This is a deep venous intervention. Look at the collaterals, look at the flow. It's not necessarily the same. It's a whole different world. The anatomy and the disease are different. Planning, imaging, endovascular tools, access, intraoperative imaging, crossing technique, stenting technique, complications, they are all different, and I'm going to explain why. Starting with the anatomy, the arteries are thick, the veins are thin. The arteries are small, the veins are big. The arteries are muscular, the veins are not muscular, they are tortuous. The arteries are high flow, the veins are low flow. The arteries have atherosclerosis and calcification, the veins have thrombus and collagen. And we start with planning and imaging. Have you ever tried to ask for a CT venogram? It's highly unlikely that you will actually receive a CT venogram. Most likely you will receive back a CT arteriogram, because our radiology labs are not used to getting CT venogram requests. So make sure when you ask for a CT venogram, you point out that you want delayed images. You want the venous phase. So you're going to ask a CT venogram, and if you have the appropriate expertise, you can ask for an MR venogram. How about the endovascular tools? Where in principle, we're using larger sheaths for veins, but more or less the wires and the catheters that we're using are the same. Having said that, we do have some dedicated crossing instruments, that the Triforce sheath from Cook. But as it comes to the wires, I typically use a stiff glide wire will be my workhorse to cross the lesion. Occasionally, you can use an O14 or an A18 wire. IVUS, it's not yet fully established for PAD or for aortic procedures, but it's of paramount importance when you're doing a venous procedure. You need intravascular ultrasound. Thrombectomy devices, they are much bigger and they are different in the venous space compared to what you're used to use in the arterial space. We are using here 10, 13, 16, 20 French thrombectomy devices. We don't use this in the arterial world. High pressure balloons, you go large in diameters, 12, 14, 16, 18, 20 millimeter balloons. We don't use them in arteries. And we now are lucky to have dedicated venous stents. There are multiple out there available. Venovo has some unique characteristics that the other speaker, Professor Jalai, will share with you in the next talk. How about access? When you're doing an arterial procedure, it's kind of no-brainer. You go at the common femoral artery. This is not the case when you're doing a venous, deep venous procedure. You should never go to the common femoral vein. You need to access lower at the femoral vein. You may need to access the popliteal vein. You may need to access the internal jugular vein. The reason is that many times you may end up standing at the common femoral vein. This may sound weird when you're doing arteries, but when you're doing veins, the stent may have to land at the common femoral vein. So access is different. How about imaging? Look at the flow. You're not used in such kind of flow or collaterals when you're doing an arterial procedure. You're not used to the IVUS images. You need to get familiar with reading intravascular ultrasound. How about crossing? Well, more or less the crossing principles are similar. In veins, you can be even more aggressive because these are low flow system, and extravasation or injury of the vein is not as bad as injuring an artery. So you can even do what we call sharp recanalization. You can use the back of the wire, or you can use needles to cross through chronically occluded veins. How about the stenting technique? Look at the image on the right. These are Venovo stents. This is how I used to do it. I used to use small, short stents, landing them at the common iliac vein. This is not appropriate in today's practice with what we know. You run the risk of getting migration if you place a short stent. You need to place a long stent, land it in the external iliac vein to make sure this will not migrate, and make sure that your stent will not have an acute angle at the pelvic hollow against the iliac vein that may lead to thrombosis. Extend below the guinal ligament. If there is disease, you have to cover it with your stent and make sure you are providing the best possible inflow to your stent coming from the deep femoral vein and the femoral vein. Complications, extravasation is rare, but even if it happens, it's low flow. All you have to do is reinflate the balloon, wait for a couple minutes, bleeding will stop. Stent fracture, placing it below the guinal ligament, if done appropriately, you may see that. And stent migration. We've seen this, it's been reported. Stents migrate, they go up to the heart, they go up into the lungs. And I will finish with this case, a 43-year-old female with a left leg venous ulcer that has been going on for 3 years. She has a history of DVT. Let's look at the ultrasound. The left leg venous ultrasound confirms chronic obstructive lesions. There is also venous reflux at the great saphenous vein, which, by the way, I ended up ablating. I ablated the great saphenous vein first. The ulcer didn't go away, so I had to jump into recanalizing the chronic venous obstruction. Now, before doing this, at that time, I did not have a reliable CT venogram. So for diagnostic purposes, I performed a venogram with puncturing the femoral vein. So you can see the multiple collaterals indicating the severe disease across the iliofemoral segment. So another day, I bring the patient back, place here on the prone position, accessing the popliteal vein. You can see a widely open femoral vein. But when you go higher, look at the common femoral vein, look at the external iliac vein, they are out. What you have to do is try to identify, getting multiple views, what we call the string sign. This is the remnant of the iliac vein. So I'm trying to cross the wire through. And once the wire is through, I'm trying to cross and recanalize with a dedicated crossing sheath. That's the Triforce from Cook. And I end up in the patent portion of the vena cava. Once my wire is through, I do the intravascular ultrasound and decide where my landing zones are to place the stent. I do ballooning, and you go aggressively. You want to balloon 1-to-1 to the size of the stent that you're going to place. So I started with a 12 and ended up with a 16 Atlas balloon from BD. And now I'm placing the stent starting from the orifice of the common iliac vein, extending down to the external iliac vein. And here I am now. I do intravascular ultrasound. I look also, there are some collaterals. There is disease left at the common femoral vein. And unless you cover that disease, the stent will not remain open for long. So I go back and place another 12 by 60 millimeter stent and look the accurate landing at the confluence. Look at the good inflow that I now have from both the deep femoral vein and the femoral vein itself. And I confirm that with the intravascular ultrasound. Complete symptom relief at 3 months, and gradually over 6 months, the ulcer healed. So to conclude, a deep venous procedure has minimal resemblance to an arterial procedure, and realizing this is a good start. Venous procedures are not that easy. Understanding the principles of venous interventions will improve patients' long-term outcomes and quality of life. Everyone can place a stent, but unless you place it appropriately, it will not last for long. Thank you.